thought this should be the first trial we discuss, because according to me, this is one of the most impactful trials which was released in the ACC this year. Now, we know that we have all been made to understand the quadruple therapy, the four pillars of heart failure with reduced ejection fraction. But we also know that very few amount of people and patients that we have of heart failure are actually on the therapy required. This trial answers a very key question, is that how soon can we start the four classes of drugs? Should we start them straight away or should we start them one by one? There have been trials in the past called the Strong HF trial, which has sort of answered similar questions. So some of the slides I have are from previous trials so that we get a context and then we know how to interpret the current trial. So the Strong HF trial, which was released in the Lancet in 2022, showed us that when we rapidly up-titrated guideline-directed medical therapy, all the efficacy endpoints that you'll see here of 180 days, all-cause death and heart failure, the heart failure admissions, and the quality of life as well as the BNP and signs of heart failure were all favorable to the rapid titration of guideline-directed therapy. So a close follow-up after discharge, acute heart failure hospitalization, when we rapidly up-titrate, it leads to a better quality of life, lower readmission rates, and a better all-cause mortality. Now we know this, but what this trial told us is something a little bit different and also really impactful. Now the objective of this trial was to see the degree in which newly diagnosed heart failure with reduced ejection fraction patients are eligible for this therapy, and there were 23,000 patients recruited. Out of these, 82% were eligible, but the amount who went home with the discharge with the quadruple therapy, that's ARNI, beta blockers, MRA and SGLT2, were about 15%, whereas 40% went back on triple therapy, and these were all initiated in hospital. Now, when we practice therapy, we know that a patient has come with heart failure, reduced ejection fraction. It sort of reflects for us to not start everything together. We'll start 1, 2, maybe 3 drugs, and then we'll say, okay, on follow-up we'll start. But this is the inhibitions that we have is challenged by this trial. And the outcomes were startling. It showed that, if you'll see this slide itself, these are absolute risks. Usually when trials are presented, the relative risk percentages are shown to us, but this is the absolute risk difference between these 3 arms. Now, the one on the top is optimal medical therapy. The one, is no GDMT. The middle arm is the one where they were on 2 drugs, ACE inhibitors, ARBs, and beta blockers. And the lowest one is people patients who went back on quadruple therapy, including ARNI. And you see the relative risk between these two was 14 and 10%, which is a 4% risk reduction. Whereas between no guideline directed therapy, that's the topmost arm, and between quadruple therapy, there was a 28% absolute risk reduction. Now, what this tells us is that although a lot of patients are eligible for quadruple therapy, yet less than 1 in 6 are actually prescribed it. And if the clinical trial benefits can be fully realized, the in-hospital titration or initiation of quadruple therapy would yield to a large absolute reduction in mortality. I think this is the most impactful trial, in my opinion, in ACC 2024, because it tells us that a newly diagnosed heart failure with reduced ejection fraction patient should not go home without all these 4 drugs, not 3, not 2, but all 4 drugs, as long as they are eligible. And remember, most patients are actually eligible.